Well, gang, I didn't want you to jump to any conclusions, but that's my daughter and I in Berlin having fun. Used to do 2.5 somersaults pike off of that, but I'm old now. Speaking of jumping to conclusions, this is week 3 of the second year fellowship, talking about disc herniation and spinal stenosis. And kind of without any further ado, I want to get to our slideshow, which you should be able to see now. So this is where we are. So last week I asked the question, just on your strength alone exam, can you tell an L5 radiculopathy from a peroneal neuropathy from a distal polyneuropathy? You still have 3 minutes to send in your answer and win $1 million. Here we go. An L5 radiculopathy has proximal and distal weakness in the L5 distribution. So the extensor hallucis and the tensor fasciae lata. Hip internal rotation is a great trick. Knees together, ankles apart, and you push them. And it's really great because if that's asymmetrically weak, you know it's the nerve root. You're that close to the nerve, right? If you just have a weak big toe, they could have stubbed it. You know, there are a lot of other things. The fact is that nerves regrow proximally to distally. So often enough, you won't find this. Often enough, the big toe will be the only weak thing. Peroneal neuropathy would only have the peroneal muscles weak, right? So if it was rather significant, you'd have the extensor hallucis, but also the tibialis anterior, which is more L4-5, and the peroneus longus, which kind of put down and out to the side like that. And of course, nothing proximally would be weak in a classic picture. But by the way, you see how I'm naming all these muscles with their nerve roots, right? So the biceps is not the biceps to me. It's the biceps C5-6 musculocutaneous. If you name them and always use that as their name, you don't have to memorize anything. It kind of comes to you after a while. Distal polyneuropathy. The real trick here is that it's symmetrical. Because the more distal muscles are a little difficult to test. The extensor hallucis you can pretty reliably measure. The flexor hallucis, patients are uncoordinated. But nevertheless, if you had both tibial and peroneal innervated weakness, and it's bilaterally, that would be pretty good evidence for a symmetrical distal disorder. So that's last week. This week, stenosis and disc herniation. You have to put these diseases in the context of what we know about back pain. In other words, the rehab doctor's job is not, I found stenosis, it's what's going on here. And you really need to understand the natural history of back pain, and you need to understand what kinds of things predict failure of treatment, and they're not obviously just the MRI scan. So first, a little review of things that you should know, which is, red flags. You remember my first question is, the patient died, what was it? And I ask you to come up with one, not a long list, because a long list is what a medical student does. One thing that's the most likely thing that killed the patient. Okay, right? That's my question. 99% of the time, you're not going to do anything except for say, okay, I thought about disc space herniation, disc space infection, but it's not, right? And the reason is because, well, here are red flags, right? Fever, night sweats, immune compromise, major trauma, progressive weakness, bowel bladder incontinence or inability to urinate, cancer history, weight loss, severe pain, night pain. You can come up with others. But if you see these, you go, that's kind of interesting. I've got a clue about what killed the patient if I ever get a phone call next month, right? But the really important thing is that these were designed to keep American doctors from ordering too many x-rays. We get sued for missing things. And it turns out x-rays are almost useless except if there are red flags. So this list of red flags was put together by scientists and policymakers to say, hey, if a patient doesn't have any red flags, it's bad to go order an x-ray. It helps us not get x-rays in our litigious society, okay? Now, they're a good clue towards disease, but when you really look at it, and we did this study, people showing up in an emergency ward, the majority of patients who show up with a back pain have a red flag, okay? The majority. So almost everybody, the doctor has to pass judgment and go, you're diabetic, but you're looking fine to me, right? And that's what you do with red flags. They're a clue towards something, but you don't have to act on them. And why wouldn't you act on them? Well, because a Canadian study showed that if you ordered imaging on everybody who had red flags, you'd like triple radiation cancer. I'm making up numbers. You triple cancer rates and drive unnecessary interventions. A classic study showed that they got MRIs on everybody when they show up in the emergency room, only told half of them what was wrong. That half, or what was wrong in the scan. People that got the information from the scan were much more likely to get surgery with no added benefit, right? So the information on tests is a very, very dangerous thing. Patients and doctors have trouble ignoring it. And so, if you have a reliable patient, if the red flags are not very impressive, if you're like, I'm really sure this is the sacroiliac joint, it's okay to wait, not forget them, but it's okay to wait and see what happens. If you do see red flags and are concerned, usually a plain x-ray and a sedimentation rate cover just about everything. If those two are unremarkable, then you're in good shape. Things like cancer and disc space infection show up pretty nicely on those two tests. In the United States, again, with our litigious society, when we order tests, we get an MRI right away. The scan company makes money. The lawyers make money if we don't. Everybody makes money by us not ordering a scan, or by us ordering a scan. And unfortunately, it's driven. And in an African context, you have to think that out in your own culture and in your own healthcare system. We're going to get to the specific diagnoses, but not during weeks 1 through 6. I don't really care if it's a herniation or stenosis or a pulled muscle or a strained ligament weeks 1 through 6, because your job in weeks 1 through 6, once you've ruled out red flags, is to get out of the way very actively. Okay, most people just get better regardless of treatment. The history and physical are usually enough to figure out what's going on. And at this level, even if there's neurologic deficit, even if there's foot drop, a herniated disc is not treated differently from other pain, okay? So what really is important in weeks 1 through 6 is to tell them what's going on and reassure them a lot. Have them keep moving, be active, have them be confident that they'll probably get better. And for the vast majority of people, that's important. I mentioned Age Indal because he got the very famous, got an award for his work showing that this is the only intervention that makes a difference in the long term. All the other things that I'll talk about don't matter really in the long term. They help the patient be comfortable, and I don't mind having people be comfortable. But in the long term, if you don't spend the time educating them and reassuring them, telling them just move naturally, get on with your life, you're not providing the #1 evidence-based treatment, right? That's how important it is. Yeah, I don't care if you do NSAIDs, ice, heat, stretching, activity, continue. Muscle relaxants, the drugs that are marketed as muscle relaxants, have no effect on skeletal muscle whatsoever, okay? They're on the market for all kinds of funky reasons, like they've been shown to help pain. But if a person has muscle spasm, the only treatment is gentle stretching and ice, okay? Or heat, okay? So don't prescribe muscle spasm drugs because somebody has muscle spasm. They don't work that way. It's really quite fine early on to have a physical therapist or chiropractor do the work, but you have to be careful because the therapist or the chiropractor may not understand what you know, and they may be all obsessed over, you should be careful if you ever pee in your pants. You're sure you're not peeing in your pants? Are you really sure? Because my God, I saw somebody 5 years ago and she's quadriplegic. It's a low back problem, right? And so you need to really be sure that the therapist understands the psychology and doesn't violate what Indal has to teach. And then, sure enough, all kinds of approaches to back pain from therapists and chiropractors are proven to help in the short term, no difference in the very long term. Weeks 7 through 12, you get to act like an internist. Find out what's wrong, fix it. All right, that's what an internist does. It's because by this time, most people are just going to plain get better, okay, enough people did. And when you get to week 12, you're getting onto some of the factors of chronicity, which put people at risk. So here's where you act like a regular old doctor. And so you get a diagnosis. First, you have a diagnostic hypothesis. Okay, you go, I'm going to order an MRI, and I think I'm going to find nothing because it looks like mechanical pain. If you find something, you got to ask, is that a false positive? Because that's not what I was thinking I'd see, right? You get an MRI and radiating pain and leg down. I bet you it's an L5S1 herniated disc. And there it is. You see an L5S1 herniated disc. That's pretty cool, right? These scans are important because they're really good at finding out whether there's anything dangerous. And some of the treatments that you're going to offer require some understanding of the anatomy and what could be dangerous in there. If the scan doesn't make sense, there's two different ways it doesn't make sense. One is you saw something and it's like, gosh, it seems mechanical. Well, that's where you do a joint injection as a diagnostic test. You think, gosh, I think it's a facet joint. So you get a facet joint injection under fluoroscopy. That's the only way to prove a facet joint hurts. X-rays, MRIs, CAT scans can't prove it unless it's a fracture, right? You think, gosh, I think this is the sacroiliac joint, but the MRI shows a big herniated disc. Well, that's when you get a X-ray guided injection of the sacroiliac joint, and the patient gets off the table and they're happy for an hour, and you go, ignore the herniated disc, right? The other way that a scan doesn't make sense is if you kind of think that it is neurologic, there's radiating pain. I mean, recall that bones and ligaments can cause pain that radiates down even below the knee, okay? Here's where you get an EMG. EMGs will detect radiculopathies that MRIs miss. Scans miss maybe 10, 15% of herniations, okay? Scans miss every chemical radiculopathy, like a diabetic neuropathy or a mononeuritis multiplex kind of neuropathy, okay? So they're not perfect. It can also find things that you'll never find on any photograph, right? If there's a distal polyneuropathy, if there's a peroneal neuropathy, if there's a myopathy, right? And you remember, of course, that there's this thing that Jeff Saul calls the pseudoradicular syndrome, which is mechanical low back pain with something else down below. Their trochanter hurts, or they got a peroneal neuropathy, et cetera, et cetera. So the workup is kind of simple. Get a hypothesis, order an MRI. If it doesn't make sense, consider either injection or EMG. Of course, you don't have to keep on doing diagnostics if the person's getting better either, right? But that's when you're done with that, you're done. There's not much more to be done, okay? You'll hear about bone scans with SPECT images. There's a place for that. I won't go into it. Flexion extension films, not your job, and they're not very helpful. All kinds of myelogram with flexion and extension and other things like this. Those are pretty obscure, and I don't think you're going to choose to do those once every couple of years. I don't know. You do have a consideration of labs. You think, gosh, this is a seronegative spondyloarthropathy, other inflammatory disorders. So there are places for labs too. But basically, MRI, then injection or EMG, and you don't want to get more complicated unless you really have a reason. At this point, this is when it's a really good idea to be sure a patient gets some time with physical therapy. The epidurals, the facet injections, the sacroiliac injections with steroids are not only diagnostic, but they're pretty decent treatment, and it's kind of worth it at this point. And in this time frame, you might decide that the person with a herniated disc is a surgical candidate, or with some other problem is a surgical candidate. As we'll talk about, only if there's clearly a target, and only if the person is disabled from major life activities, despite the possibility of just riding it out, because people still just get better, okay? Once you get to week 12, I don't care what their MRI shows or their EMG shows, I mean, you're obligated to find out and you're obligated to treat, but the money's at this. The money is doing rehabilitation diagnostics, right? So you're looking for deconditioning, you're looking for mental health problems, you're looking for social barriers, you're looking for things that have to do with function, not necessarily the anatomy. Why? Because at 12 weeks of significant disability, people have taken on the attributes of a chronic pain patient. They've got fear of movement. They've gotten used to watching football games in the middle of the day instead of going to work. They've developed a sense of hopelessness. Depression is rampant, anxiety, et cetera, et cetera. And those are all very reversible causes of disability. So far, I've been talking about general stuff, but that's the framework in which we are going to talk about a herniation. So I got a question I'm not going to have a slide for. What are the physical exam findings for a lumbar disc herniation? I want you to write them down. At the end of herniation, I'll talk about it, but frankly, you should know these from being a medical student, okay? What are the physical exam findings from a lumbar disc herniation? What are the physical exam findings from a cervical disc herniation, right? And I'll come back to that at the end. but I want you to think about it, write some stuff down, turn off the computer for a minute and go do that. You know, who hasn't seen a herniated disc before, right? By the way, this is a T2 sagittal image, and it's the best first thing to look at for herniation. So when I'm looking at an MRI in some detail, I'll first look at the midline sagittal film, and I'll take a look at the bone quality. I'll take a look at the discs, and they get darker down here, right? I'll look at the white water, the spinal fluid, and the fact that something's scrunching it. Of course, this is your herniation here. I'll look at the tip of the conus medullaris to look for surprises. People miss tumors of the conus all the time, right? And that's where I start. If this is normal, there is a possibility of a far lateral disc herniation, and you shouldn't ignore that. But the 80-20 rule says that this one picture shows you most of where you're going to find other things, and then you go on to look at the rest of the scan. You see the distributions L1, L2, L3, L4, L5, S1. They don't have sacrum. I didn't see that. S1 to the bottom of the foot, right? So you've seen herniations. I want you to understand herniation in a different way. If you look back at a book I've got from 1905 called Medicology, okay, in the 1800s, they knew almost everybody got better. And the treatments were kind of like how you treat inflammation, or how they treated the flu or the common cold, and poultices and stuff to decrease rest, and people just got better. Okay, it was like they had some inflammation in the spine. Here in Vermont, we have a very small, trivial, nobody knows about it, but really cool piece of history, which is in the 1930s. And I was told this by Phil Davis, who was the very old orthopedic surgeon who was a young doctor when this occurred. There was a guy who came to University of Vermont with what they thought was a painful something or other. They called it a tumor of the spine. And the local orthopedic surgeon said, you know, I've seen hundreds of these. It's just going to get better. Just relax. And the guy was uppity about, damn it, I'm getting an expert. So he traveled down to Boston, where doctors Mixter and Barr did a lumbar discectomy on him, the very first one, and he got out of surgery and was doing great. So now all of a sudden we have an operation to treat a herniated disc, even though they usually get better, okay? Around the same time, by coincidence, in the United States, workers were organizing, and they'd gotten to the point where they could get enough money to hire very expensive lawyers. So if somebody got killed on the job, a company could be sued and go bankrupt. And the compromise is that every state in the United States developed different rules, but rules that basically said if you're hurt on the job, if an injury on the job, you don't have to prove it's your boss's at fault. In exchange, you can't prove pain and suffering and things like this, right? So now what do you have? You have herniation becoming an injury. I got hurt at work, okay? And surgeons going, I can help you. And the lawyer going, and if you get surgery, now I can prove that you had an injury that has permanent impairment. And the whole ball of wax continued on and on and on. But if you listen really carefully to people with herniated discs, and if they're honest and introspective, they'll often say, I felt kind of funny on Tuesday. And that's okay. And then Wednesday, I don't know. And then Thursday, I lifted a blue pencil at work and pop! And my foot started on fire and I had foot drop and, you know, et cetera, right? It was going to happen anyhow. When you look epidemiologically at the prevalence of herniation and the incidence of herniation in industrial workers and non-industrial workers, it's just not that much different, okay? So we all call it a work injury. And honestly, I don't feel bad about that, because often we kind of believe that it has a lot to do with repetitive work, et cetera, et cetera. But our legal system calls it a work injury. And everybody in our system is taught, when did you herniate your disc? What caused the herniated disc? Oh, by the way, don't ever lift a blue pencil again, okay? 1990s, Joel Saul, I talked about them before, and others, found out that the pain from herniation comes from inflammation, not even of the nerve. Inflammation of the nerve just causes weakness, but the pain is inflammation of the nerve root sheath, which has sensory fibers, okay? And so you'll see somebody who has a foot drop without any pain whatsoever, and they just never inflamed their nerve root sheath, which is kind of weird, but you'll see a foot drop, and it's a herniation, and there's no inflammation. people have shown that almost everybody who doesn't get surgery gets better. This sounds like the 1800s, right? And we showed, we worked with an insurance company in Western Michigan. We said, family doctor sends somebody to a surgeon. Surgeon doesn't get paid unless the patient gets one visit with a rehab doctor. One visit with a rehab doctor in a patient who's expecting surgery got rid of 1/3 of back surgery in the whole western part of the state, okay? So these days, the challenge is, what does society do with a bunch of really smart, really rich doctors who love to cut? What do you do with the careers of a bunch of spine surgeons? And spinal injections have become very profitable in the United States. And anesthesiology, instead of putting people to sleep all the time, has a subspecialty of spinal injections, epidurals, facet injections, et cetera. Everybody would say that they're way overused, and they are useful, way overused. But when you read the literature and you put this in the context of Africa, you realize that the literature is written from industrialized countries that have this pressure to do things that are not exactly what the pathophysiology says. So when you think about herniations, remember Kirkcaldy-Willis's normal degenerative cascade, right? You get the change in configuration of the proteins of the annulus and annular tears, and then the disc collapse, but sometimes the nucleus squirts out, et cetera, et cetera, et cetera. It's normal in every animal, human, dog, cat to have this process. And by the way, sometimes before the nucleus material dries out, it squirts out someplace. Hey, if it squirts out anteriorly, we see it all the time on scans. It has no effect on pain whatsoever. If it squirts up into the bone through the end plate or down, that eventually on a plain X-ray is a Schmorl's node, which looks like a soldier's helmet in the MRI, right, or in the X-ray. And now we know that when that happens, it's probably transient mechanical back pain. People have a couple of weeks of back pain, oh man, and then they finally get better. And it's because they broke a little crack in the bone, right? Most herniations that go posterior don't hurt. We know that because 1/3 of normal people without any pain have a herniation in the back. So why do some people have horrible shooting pain, nerve damage, et cetera, et cetera? It's because for reasons that are odd and not fully fleshed out, maybe having to do with the immune response to oral flora, for instance, right? These people have a really big inflammatory response. What I'll tell patients is hot chili pepper sauce is touching your nerve. It's not pinching your nerve, it's not squashing your nerve, but hot chili pepper sauce can hurt like hell and it can cause nerve damage. You can move any way you want because it's not pinching your nerve. You can go play football. You can, if you can do it, it hurts, but you're okay. It's not a dangerous thing that's pinching, and if you sneeze, it's going to make you paralyzed or anything like that. But it's hot chili pepper sauce, okay? Over time, the inflammation burns out. And our studies, many studies have shown you get somebody with a clear-cut, acute, horrible herniated disc and a great big herniation on their MRI scan, and they get better through conservative means. And you take a look at the MRI and it looks unchanged. Still got a great big herniated disc. Oh, by the way, if they broke their big toe, now they got back pain and pain in their toe and they got a hernia, and someone wants to operate on them for the big toe. Ridiculous, right? So you got to be really careful because looking at the scan will not tell you that the herniation still hurts, okay? Over time, the herniation actually does dissolve and you just get the simple collapsed disc, just like anybody my age has anyhow, right? There is a place where you can get a pinched nerve in the back. That's called cauda equina syndrome, and you know what that is, right? Progressive neurologic deficit, bowel incontinence, bladder incontinence, or bladder retention. That's an emergency. Number of hours until surgery dictates whether they're paralyzed and use a catheter. That's really important to know. But it happens in maybe about 0.7% of people with the herniation, okay? And it doesn't happen because they lifted or bended or twisted. It's just, how does my friend Auge say it? Shit happens. It's random. So making somebody afraid of the possibility of cauda equina syndrome causes disability. Making them aware of it casually so they understand what an emergency is different from saying, be careful, don't lift anything because you might pee in your pants the rest of your life. That is really dangerous talk, right? So you need to understand the pathophysiology. So we treat pain lots of different ways. What's really specific to treating a herniation? Well, education, like I just did with you, is really important because patients have internet, patients have rumors, patients are afraid, even if they're not well educated. You have to tell them it's not dangerous, that they got to keep moving, that they'll probably get better. Physical therapy. Robin McKenzie's work has best research. There's good evidence that said McKenzie exercise can help with herniated discs. It's a great idea. There are other techniques of therapy which are not bad at all, less well researched. So you kind of go with what your therapist knows. We used to put people to bed with this all the time for weeks at a time. I have the rare patient which just, screaming pain, horrible, horrible pain. I get an MRI in those because I'm worried about what's going on. But there are occasional cases where I'll put them to bed with diazepam, an opioid, make them get up once a day to walk, and just cool it down for a couple of days. But I talk a couple times a year. It's really uncommon. There's no medication right now that's currently specific to herniation. There are experiments coming around where people look at that phospholipase A2 and the other inflammatory chemicals and say, we're going to come up with one. But right now, there's none. People use oral steroids. There's some support for using them. There's some support for the fact that they cause osteoporosis in women and stomach ulcers and make people feel crappy. Far inferior to an epidural injection, but okay, epidurals are a really good idea. The research started out very enthusiastic, and then it backed off a little. And the thing we know for sure is in people who look like they need surgery, and you do an epidural, you derail the idea that they need surgery in a significant number in randomized trials, right? So it has some effect in derailing that process. And why? Because probably they hurt less, possibly they get confidence that there are other pathways. Beyond that, my opinion is epidurals really do help, and I don't do epidurals, so I'm not selling what I know, what I do. They can really help. They're a really good idea. Like nobody should go to surgery without trying epidural first. You have to hit the right spot. So your neurologic examination, your MRI, and if you have an EMG, to find better outcomes. If epidurals are driven by the results of an EMG, you get better outcomes than if you drive them based on an exam and an MRI. But you don't get an MRI, an EMG on everybody, you just do an epidural. Transforaminal is much better than caudals, but I recognize that without a scan or x-ray, you can do a caudal. So there's a place where you may end up doing caudals anyhow. Surgery for herniation is a good idea. Some people think that I'm like the evil one against surgery because my research shows how to get rid of surgery. But honestly, it's the right thing to do for people. The thing is, beauty is in the eye of the beholder, and surgeons are generally not so well trained at how to avoid surgery. Okay. And that's where you jump in and you help out. But you get a person that's been educated, had physical therapy, tried the medicines, tried the epidural, and then the indications for surgery are social. If you're a rich doctor, you can afford to wait. If you're a professional footballer, you can't afford to wait. If you've been waiting forever and you're getting burned out and sick of it and depressed and you can't handle the pain, surgery is a great idea. So surgery happens because of failure of conservative treatment. But you as rehab doctors are the ones who determine whether conservative treatment failed because you're the expert on function and quality of life and pain, and you're an independent arbiter of that. Again, emphasis, surgery is a good treatment. What does the research say? It was hard to prove surgery helped because when they did the randomized trials, and there's the sport trial out of Dartmouth down the road here, it basically, some people argue that sport did not show surgery help, but if you look at the way that the surgeons, I think, correctly interpret sport, it was hard to show that it worked because when they randomized everybody, almost everybody on both sides got better, whether they got surgery or not. Who's to tell surgery is better? Well, probably surgery speeds up recovery. You're going to get better anyhow, but surgery speeds up recovery. Okay. Does surgery make a difference with pain in the long term? The evidence is weak. Surgeons say yes, the evidence is kind of weak. I wouldn't dismiss it. Does surgery make a nerve grow back faster? Heck no. So foot drop is not an indication for surgery. Pain is, okay? The nerve's already been damaged. There's been Wallerian degeneration, and that's like removing the pickaxe 3 hours after you cut the cable. You're not going to get the cable to grow back because you remove the pickaxe. So surgery is a good idea, but you have to be smart about it. Okay. Herniated disc. What was your physical exam? Well, there's nerve tension signs. In this case, it's the straight leg raise test, or for a high lumbar disc herniation, it's a reverse straight leg raise test, right? You lift have them on their belly. There's sensory changes. And you know how I do that? I go, are you numb? And they tell me. I don't worry about mapping it out too much, okay? There's reflex changes, right? L4 is the patella. L5 is the medial hamstring. S1 is the Achilles, right? And there's strength deficit. And, you know, my exam is really stupid because it always works. Toes up and down, ankles up and down, knee backward, forward, hip up and down, internal rotate, external rotate, adduct, done, okay? And you can map out which nerve root goes to which of those. But if you do that exam, it takes you like 2 minutes and it finds things and you can map that out. Cervical herniation. The tension sign is a Sperling test. They turn their head this way and you crunch down, they get pain that radiates below the shoulder. We did a study, Hank Tong and I did a study that showed that if that's true, there's a good chance their EMG will be positive, okay? Strength examination is a little more complicated, right? Grasp is great to see what their level of effort is. If they don't use their pinky, they're probably not trying very hard, okay? Finger extension, pinky down, peace sign, thumb like this to get the median, especially for carpal tunnel, okay? Then wrists up and down, elbows up and down, shoulders out and back. Shoulders external rotate is just like the tensor fasciae lata in the leg. That's really super because that'll pick up C6, and you'll see if somebody goes out and one arm goes, and either they rip their rotator cuff, which is common in older people, or they have a C6 radiculopathy, and that'll be the thing you pick up. Reflexes. The biceps is C5. The brachioradialis is C6. The triceps is C7. And I just learned this. The flexor pollicis longus, you hit right here on the forearm and the thumb goes ding, is C8. And those are your reflexes. And sensation, you know, this is the 6 shooter. It's like a gun, but this is C6. C7, C8, T1, C5 up here, but the 6 shooter helps you to remember where everything is, right? Okay, let's go on to stenosis. Want you to go Google spinal stenosis, look at what they're teaching the lay public. Okay, I want you to see what the public is learning about stenosis. They talk about getting an MRI. I dare you to find out which criterion a radiologist should use to say that an MRI is abnormal versus normal. Go ahead, start looking. We'll come back to that over time. It's kind of scandalous. So you've seen stenosis. It's a real thing, right? This person happens to have a listhesis here, but the idea is that the spinal canal gets too tight and the nerve roots wrinkle up like that, right? And the symptoms, they're worse with standing. When they lean forward, they feel better. When they sit, they feel better. They get neurogenic claudication, right? So the person walks and they can get 100 meters or 50 meters and they've got to stop and they got to bend over to get relief. That's a trick because the other cause for claudication, of course, is vascular disease, right? And we did a study where a vascular surgeon and a neurosurgeon couldn't agree about whether the person had neurogenic or vascular claudication, right? So you know, you can look at pulses. You're going to consider the possibility. You're going to maybe do an ankle brachial index, which is sensitive for vascular disease, but not specific to claudication. So a positive ankle brachial index doesn't mean that it is claudication, but a negative one kind of makes you think it's not, right? Let's see, next slide. What do we have here? Next slide, please. There we go. The definition of stenosis is a fraud. It has been. A clinical syndrome, okay, not an x-ray, but a clinical syndrome of buttock and lower extremity pain, which may occur with or without back pain, according to NAS. And it's associated with diminished space. Throw me a number on that one. Throw me what is the buttock pain really like? And if I sprain my ankle and I don't have back pain, is that lumbar stenosis? Well, only if the MRI shows diminished space. What's diminished? What's diminished? Well, if you get a bunch of cadavers and you find out that the average spinal canal is greater than 12 millimeters diameter, but the standard deviation is such that 9 millimeters is 2 standard deviations out. Some idiot decided that since it's 2 standard deviations away from normal, then it's pathological, right? And then the idiot didn't figure out that if you use 2 standard deviations and you measure it at L5S1, and then you measure L4-5, and L3-4, and L2-3, that all of a sudden you've got this Bonferroni correction that needs to happen. Multiple repetitions, you flip a coin 100 times, it'll show up heads 5 times in a row just by chance alone, right? Completely mindless stupidity. Now, the doctors aren't stupid. The doctors see people with tight canals and neurogenic claudication and they fix them, but the definitions are just goofy and you need to be very careful of what you've learned. Everything you've learned is wrong. Back in the day, Verbiest wrote the first papers in the 1950s and 60s and was measuring the spinal canal on an X-ray. And then they started using myelograms, and then they started using CT scans, and then they started using MRIs. And the further and further you got into looking at the details, the more and more people looked like they had disease, until we did a study where about half of our patients had moderate stenosis and about a third of them had severe stenosis without any symptoms. They weren't patients, they were normal volunteers, okay? None of these tests can positively differentiate a person who has symptoms from a person who doesn't have symptoms. You must ignore the scan in making your diagnosis. You can use it to say how deep you put a needle. You can use it to help say which level it's at, but you cannot use the scan to just say this person has stenosis and this person broke their toe. Can't do it, okay? They still claim that these imaging are required for the diagnosis, and none of them have a criteria by which you would say there's a cutoff that says it's normal or abnormal, okay? So here's an example. This is a nice lady who has low back pain, pain into the right hip, spinal canal, you can see is pretty darn tight. But turns out that when we injected her sacroiliac joint, all her pain went away. Oops, right? Here's another one. She has back pain. I'll never forget this lady. I know her name. Back pain, leg pain, weakness, showed up as a research subject on our trial because she was scheduled for surgery and she qualified for a trial. EMG showed conduction velocities of 22. Her leg pain and weakness was due to Charcot-Marie tooth disease, which is a peripheral neuropathy, and the back pain was mechanical. But her scan showed some stenosis that would qualify, okay? Again and again, you can't look at the scan, okay? The pathophysiology, though, is that the spinal canal is too small, okay? Back to William Kirkcaldy-Willis, right? As the discs collapse down, the facet joints in the back begin to bear weight, those guys. They get bigger to do that job, which is really nice of them, right? But as they do it, of course, the hole that the nerve comes through gets smaller, and you get lateral recess stenosis, and the circle of the spinal canal gets smaller, and you get radiologic smaller canal. I hesitate to use the word stenosis, even though the radiologists do, because stenosis means too small, not small, right? Also, though, as people stand, they get segmental shifting, and all of a sudden you get pinching, right? And there are things like ganglion cysts and bulging discs and other things that make the canal smaller. And what you have to remember when you're looking at the MRI or CAT scan of a person who's lying down, okay, they didn't say, "Doctor, my back hurts so much when I lie down in a scanner," right? They're getting a photograph taken of their back when they do not hurt. And their pain only occurs when they're standing and walking, right? So just continually doubt what you see in a picture. Can I beat that to death? I guess so. So classic neurogenic claudication, Mr. Porter, a British surgeon who's a wonderful old guy, did studies in animals and follow-up in humans. And it shows that the neurogenic claudication is venous congestion. So Batson's vein plexus has blood flow up and down and back and forth. You got to block it at one place and block it at another place. And now all of a sudden you get venous congestion and the veins start squishing the nerves and you get this neurogenic claudication. Person bends over, they empty that area out, they can get going again, right? That's the story of neurogenic claudication. What it means is it's often a temporary nerve injury, like tapping your elbow, which would cause a negative EMG. I can feel it, ting, but it kind of doesn't cause axonal loss in some people. The more severe the stenosis, the more positive your EMG is going to be. Central stenosis often has symmetrical leg fatigue. And lateral recess is often one root, L5, something like L4, something like that, right? What's really interesting to me is you should look at the back pain in stenosis as not being caused by the stenosis. We can be wrong. There are people where they get claudicatory back pain, but most of the time, the back pain is because they jammed a facet joint or the sacroiliac and they're bent forward and their hips are tight and they get trochanter tendonitis, et cetera, et cetera, et cetera. So when you see a person with stenosis, surgery for the back pain from stenosis is pretty dicey unless you're really confident. Surgery, for instance, for the leg pain is something that fits into the collection. So when you see back pain and stenosis, look for the other ways to treat the back pain as a second diagnosis. Not always true. So our team looked at all this crap and said, we have to do something different. And we, just one second, I can't stop now, I have to keep going, sorry. So we knew that there was no actually specific or agreed upon criteria for what the syndrome was, what patient findings would make somebody meet the criteria. So we did a computerized survey of clinicians around the world. Now, most practice guidelines are made by a bunch of medical politicians. I've been on them, and I was like, I'm the rehab doctor, and you have to do what I say because, they're political, right? We made it apolitical. Anybody who's a spine expert want to jump in and ask. And so we'd present a case, and then we'd say, to what extent do you think this is stenosis? And then we'd say, oh, by the way, she can't walk more than 50 meters. Now, how certain are you that it's stenosis? We kind of did this thing with hundreds of doctors around the world and got the big International Spine Society Award for coming up with a consensus syndrome, not one based on medical politicians, which are surgeons or rehab doctors or whatever, right? So as you go through these questions, the one that was really important is there leg or buttock pain with walking? Is it relieved when they flex forward? Does shopping cart or riding a bicycle help? Are there motor or sensory changes? Are their foot pulses intact? And you get beyond there and you get to diminishing returns. And when you get beyond there, you get about 80% certainty that it's stenosis. So when people follow that set of rules, then you've got 80% certainty that an expert clinician would think that the person has clinical spinal stenosis. So that's a criteria clinically based on history and physical for clinical lumbar stenosis. It's what we go by now. It reaches an asymptote. Is 80% good enough? It's good enough for talking to the patient. It's good enough for pills. It's good enough for therapy. Might be good enough for an injection. Is being not certain good enough for surgery? We did another study with two different surgeons examining the patient, and the disagreement between them about whether the person had neurogenic claudication was 20%. So you got people who have been offered surgery, and one surgeon doesn't agree that the person has what the other surgeon thinks, right? So there's some vulnerability here. So we talked about what the syndrome is. Be creative. This is just our set of rules. You can come up with other exceptions. There's things like Vesper's curse, where people who have congestive heart failure and spinal stenosis, when they lie down at bedtime, the blood pools into their spine, they get claudication and they feel horrible at night. There's neurogenic ataxia, where the person walks and they don't necessarily get pain or weakness, but they feel like they're drunk because they can't feel where their legs are. So we also did a bunch of work on EMG. It is really very definitive, okay? So we have this technique we'll talk about next month called paraspinal mapping. We had a double-controlled trial. That means people who had no pain, people who had mechanical back pain, mixed in with people that had what we thought was spinal stenosis. And this paraspinal mapping had a discriminant value. In other words, statistical significance means, on the average, and I never met an average patient in my life, okay? And there's mild statistical significance with spinal canal diameter with populations, but you can't use that to say your canal's under 9 millimeters, let's cut. It doesn't work. EMG, paraspinal mapping score greater than 4, has a discriminant value in separating the population. So it's kind of diagnostic, okay? It's true that mild to moderate stenosis, you'll miss a case. And I've had the occasional case of people quite disabled by stenosis. I knew they had it clinically and the EMG was negative. So it's not perfect, but when it's positive, you can kind of bet your house on it. Oh, by the way, when you do the EMG, you'll find all these other pseudoradicular syndromes like the statin myopathy, the polyneuropathy, the peroneal neuropathy, because they cross their legs differently, right? Treating, Chrissy Tompkins and I wrote a nice article in JAMA about how to treat it, and it's just common sense steps, okay? You can leave it alone because some people get better. Just working out is helpful. Being stronger gets you through stuff. Specific physical therapy, there's growing research that some of it helps. It's not a miracle cure, but it's a good idea. General reconditioning with coaching by a PT is often important because the stenosis makes it so they can't just go jog, right? We did a study, Agnes Walbaum and I, showing that if we made them push their limits, you can walk 100 meters, walk 105, walk 110, that people's walking got better. To what extent that's functionally useful use of their time is a question. Rehabilitation is not physical therapy. Rehabilitation is how do you live with this, right? And if the indications for surgery are, failed conservative treatment and interferes with quality of life, well, what if they're depressed? What if you just need to move their mailbox closer to the house? What if you can do things that are conditioning, ergonomic, psychological, and social that make their quality of life such that this disease is not having an impact on their life, right? Epidurals, increasing research is disappointing on epidurals. Here's a place where I think they kind of help, okay? But the research is getting a little bit, okay? I would always try an epidural before surgery. And I have patients who go to Florida for the winter and come back saying it wore off. And I'm like, well, it obviously worked if it wore off. But the science isn't really as good as it used to be when people were going crazy with the epidurals. And here's another place where surgery is a good option. But again, you want to take a really good look at why and when. You've got to have an EMG, okay? EMG detected in our study of 150 people, 7 people who we thought had stenosis, and I think 5 of those we thought had stenosis were on the line for surgery. We found a polyneuropathy of some kind. Diabetic neuropathy, they didn't even know they were diabetic, myopathy, et cetera, et cetera. So you don't want to do it without an EMG. Research we didn't do shows that paraspinal mapping findings make it so you can do less extensive surgery, okay? The patient has to fail all these other treatments. They have to be disabled from activities that matter to them. Why would you treat difficulty walking 100 meters if the patient never does it? The stenosis must be the key disabling illness. What if they're really disabled by heart disease and you fix their stenosis? What if their knee arthritis is really the rate limiting factor? What if depression means that they're not going anywhere anyhow? Treat the disabling disease, right? They have to be medically stable. You're all expert on that. And then surgery's a good idea, okay? It's not perfect, by the way. The research has shown that for people where they're doing surgery on the back for this kind of problem and segmental problems, that laminectomy is almost always the answer. 2 different randomized trials show that fusion just adds to the operation and complexities. Laminectomy gets the job done. Respect your surgeon. Respect your surgeon. Sometimes there are biomechanical things that make your surgeon really want to be sure that that hard scoliosis gets rotted and stuff like that. But more or less, run-of-the-mill stenosis needs laminectomy and nothing more. It's actually really good in the short term, and patients are really grateful. And for many people, for a lifetime, they're really grateful. It improves their quality of life. If you have somebody who exercises, it helps them to stay active so they don't die earlier, right? It's a really good idea. And in the long term, it's actually usually a good idea too, but you need to know that there are recurrences in a certain number of people. 5, 6, 7 years later, their stenosis comes back, and then what do you do, right? And people die of surgery too. Ted Cole, the former chair of my department, woke up dead from his spinal stenosis surgery, and it was really tragic. But that's a war story. I advocate for stenosis surgery in this population. So it's a good idea. Okay, last slide. Next week, I want you to start looking up papers, looking up things that are factors that predict somebody's going to be disabled. And the second thing that I'll ask you to do, not this week, which is tomorrow, but next week, is have you mimic a little bit of a speech that you'd give to a patient with an acute disc herniation. How would you talk to the patient in 5 minutes or 2 minutes or whatever you have to describe what's going on? With that, I think that I should probably quit and hope you all have a good day. Bye.